Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, president of RhAPP, and today we're kicking off something extraordinary, our EULAR Psoriatic Arthritis RhAPP Up series. Throughout this three-part series, we'll be breaking down some of the most important and practice-changing data coming out of the 2026 EULAR Congress. For today's episode, I'm excited to be joined by the amazing Audrey Gibson. Audrey is RhAPP's newest board member and brings extensive experience and expertise. Audrey, before we begin, is there anything that you'd like to start our listeners out with?
Well, first off, just thank you so much for having me. I'm excited to go through some of these EULAR presentations. But I'm Audrey Gibson. I'm a physician assistant from the Arthritis Center of North Georgia in Gainesville, Georgia. And I've been practicing there for 20 years. So I'm just excited to be here and part of RhAPP.
Well, we're so excited to have you. And it's so funny because I always say this to my patients, and I'm sure you're doing the same, like we're all growing old with our patients.
Yes, absolutely.
And, we've been practicing the same amount of time. And so we really have seen this era of new therapies. And it's just been so incredible to even have these discussions because 20 years ago, we certainly weren't talking about, all of these new therapies that are implementing, how we change practice for our patients.
No, it's incredible to see kind of the evolution and better therapies, safer therapies, and it's to have all of these options, EULAR and ACR, these are my favorite times of year because that's when you get to see all of these new molecules and new mechanism of action. And, that just means a lot for us and it means a lot for patients. So
Absolutely. And, it's so incredible that RhAPP is at the forefront and getting this data out to our listeners as soon as it's coming out. So with that, let's go ahead and jump right in. So I'm going to start us out by talking about abstract LB0001, and it is bimekizumab efficacy and safety versus risankizumab in patients with active psoriatic arthritis, a 16-week result from a head-to-head multi-center randomized phase 3B study, otherwise known as BE-BOLD. So the overview of the study, the BE-BOLD trial was a head-to-head study evaluating the efficacy and safety of bimekizumab compared with risankizumab in patients with active psoriatic arthritis. The study focused on whether dual inhibition of IL-17A and IL-17F with bimekizumab could provide superior clinical outcomes compared with the IL-23 inhibition alone. The background, psoriatic arthritis, as we know, is a heterogeneous inflammatory disease involving multiskeletal and dermatologic manifestations that can significantly impair quality of life and physical function. Although IL-17 and IL-23 inhibitors are both established therapeutic approaches in psoriatic arthritis, direct comparative data between these mechanisms of action have been limited. The purpose of BE-BOLD was to determine whether bimekizumab could achieve superior disease control versus risankizumab in patients with active psoriatic arthritis. The methods, BE-BOLD was a randomized head-to-head clinical trial in adults with active psoriatic arthritis. Participants received either bimekizumab or risankizumab, and efficacy was addressed using standard psoriatic arthritis clinical endpoints. The primary endpoint evaluated achievement of ACR 50 response at week 16, which is a stringent measure reflecting at least 50% improvement in disease activity. Safety outcomes and tolerability were also monitored throughout the study. The results, so bimekizumab demonstrated statistically significant superiority over risankizumab for the primary endpoint of ACR 50 response at week 16. These findings marked the first head-to-head psoriatic arthritis study showing superiority of an IL-17A/F inhibitor over an IL-23 inhibitor using this stringent endpoint. Treatment with bimekizumab was generally well tolerated, and no unexpected safety signals were reported during the analysis period. The author's conclusion was that the Be Bold trial demonstrated that bimekizumab provided superior improvement in psoriatic arthritis disease activity compared with risankizumab at week 16. The authors concluded that dual inhibition of IL 17A and IL 17F may offer more complete inflammatory control in psoriatic arthritis and could represent an important advancement in treatment selection and optimization for patients with active disease. Okay, so I feel like we have a lot to unpack here. Audrey, what are your first thoughts about this study?
I think, when you see this study, the very, very first thing is it is a head to head trial. And I think in rheumatology, in clinical practice, we always love to see head to head studies. Unfortunately, we don't have that many in the rheumatology space. I'm always jealous of our dermatology counterparts. They have tons of head to head. We don't really have that here. So to see that head to head data, against another MOA, is really exciting to me. It's really interesting to me to see how the two compare against each other.
Yeah, I totally agree. I mean, we always ask for this, and so it's incredible that we actually have this, to look at. And I think, again, number one, I think these are both the mechanisms I think are amazing, and I think that as we look at a more domain based approach for psoriatic arthritis, I feel like this is potentially something that could gear us maybe more towards one way based on the patient, potentially versus another. But to me, overall, I think that this is exciting. And the first thing that I kind of think of is, okay, we have 16 weeks, right?
Right.
So if we potentially have a patient that is perhaps someone that we really want to get their disease under control really fast, or maybe faster, maybe I would gear a little bit towards an IL 17 agent over an IL 23, which is kind of what I'm already doing. I don't know if this is
Yeah.
what you're doing. This is kind of what I've seen in clinical practice. Are you kind of doing the same thing?
I think they just honestly, this kind of solidifies a lot of things that we're doing in practice, kind of reinforces some of our thought process that we already have. And exactly to your point, if you have that patient that you're like, we really need to get this patient under control a lot quicker. Again, this kind of confirms that thought process in our head that this, bizakizumab is going to get there faster than risankizumab. I think I would have loved to have seen what happened a little bit later. If you had carried it out a few more weeks, what would have happened to risankizumab. But I think you're exactly right. That's kind of my thought process in the clinic when I see patients. And again, really assessing that patient where they're at, what domains are present, how active their disease is, and, again, that decision making process with the patient, what our goals are for that patient, and getting them under control a lot faster is really important.
Absolutely. And to your point, hopefully we'll have data further out so we
Yeah.
can see, like, does it kind of level out at, 6 months or a year or whatever. But no, I totally agree. And I think, then we kind of get into the 17A and F and, potentially what does that mean, versus some of the other IL 17s, and does that matter? I tend to think potentially it does, for certain patients, but no, this is so nice, and again, I think definitely needed because especially newer, APPs or all of us really, we need to understand what is the correct drug for the correct, for the patient. And we have so many options now, which is wonderful, but really being able to see your patient and say, okay, based on your domains, based on your disease activity, because I certainly have people that their main issue is more the skin and a little bit of the joint, or vice versa. And maybe they have no IBD or no, none of some of these other manifestations. So kind of understanding then which is the correct first line therapy, because I really do think we're also shifting our ideas on that, in terms of what is appropriate. Now, of course, taking insurance out of this, but what is the most appropriate therapy for that patient?
Yeah, absolutely. No, I think that's that's our whole goal. It's really more that precision medicine, which again, there's been huge advancements in that, but we're still not there yet. And again, it's about picking that right drug at the right time for the right patient to ensure that they're going to have the best outcome possible. So,
Absolutely. All right. Do you want to talk about another abstract
yeah.
for
So,
us?
okay. So let's get into the second abstract. So this is OP0073. This is isocapep. Sorry if I'm butchering that name. But it's an IL-17A inhibitor, demonstrates rapid and robust improvements in patient-reported outcomes in psoriatic arthritis. So the overview of this study is this study evaluated the impact of isocapep, a small protein therapeutic targeting IL-17A, on patient-reported outcomes in patients with active psoriatic arthritis. Investigators assessed whether treatment with isocapep could rapidly improve symptoms that matter most to patients, including pain, physical function, fatigue, and quality of life. So, a little bit of background. Psoriatic arthritis significantly impacts physical functioning, pain levels, fatigue, and overall health related quality of life. While many therapies improve objective disease activity, patient reported outcomes remain critically important in evaluating meaningful clinical benefit. Izokibep is a novel IL-17A inhibitor designed with high potency and tissue penetration. This analysis aimed to determine the speed and magnitude of PRO improvements associated with isokibep treatment in active PsA. So, looking at the methods, patients with active psoriatic arthritis were enrolled in randomized clinical study evaluating isokibep. Multiple validated patient-reported outcome measures were assessed over time, including pain scores, fatigue, physical function, and health-related quality of life assessments. Changes from baseline were compared between isokibep-treated patients and placebo-treated participants across multiple study time points. When they looked at the results, the isokibep treatment resulted in rapid and clinically meaningful improvements in several patient-reported outcomes compared with placebo. So patients receiving isokibep experienced reductions in pain and fatigue along with improvements in physical function and overall quality of life measures. Benefits were observed early in treatment and were sustained throughout the evaluation period. The magnitude and consistency of improvement across multiple PRO domains suggested broad symptomatic benefit for patients with active PsA. So the authors concluded that isokibep demonstrated rapid, robust, and clinically meaningful improvements in patient-reported outcomes in psoriatic arthritis. These findings support IL-17A inhibition with isokibep as a promising therapeutic approach capable of improving both disease activity and patient quality of life. All right, so let's dive in here a little bit to this. So, what are your kind of first impressions of this one?
Well, again, my first thought always is, "Yay, another therapy for us." Um, and I think, this would, I guess, what be the 4th IL-17 that we
Yes.
would have, right? And, initially you're like, "Gosh, do we need another one?" But to that point, I mean, we have that many of our anti-TNFs, and, I will say that I think always more options for our patients is better. I guess I'm not surprised that this is working because we already have that, data from some of our other agents that are IL-17As and that work wonderfully for our patients. And so, my initial thought is, this is great, another option for our patients. I'm sure it will have space, in the landscape for psoriatic arthritis. And I'm interested to see a little bit more about, what this drug is, how it works, additionally, in terms of the efficacy, safety, etc. But all in all, I would say, yeah, that's great. We'll have potentially another option for our patients.
Yeah. No, I kind of had the same honestly, I had the same kind of thought process when reading through this. I thought, "Okay, right, do we need another IL-17?" But again, I think options are always great. More options are fantastic. And I think, again, how does it compare to the other IL-17s? How is it differentiated between the other IL-17s? Where is its place in that patient treatment algorithm? I thought what was really kind of interesting here is that they really looked at PROs, instead of looking at your traditional, ACR 20, ACR 50, ACR 70. I'm sure they have that data somewhere. But this particular abstract was really looking at patient reported outcomes, which I thought was really, really interesting, because a lot of times, sometimes our goals for patients and patients' goals for themselves, they don't always match. And so, to have that kind of different approach in that in this abstract was kind of interesting to me anyway. So kind of a different approach for patients.
Yeah, that's a really excellent point. So, I think more to come from that. Well, that wraps up part 1 of our EULAR Psoriatic Arthritis Wrap Up. Be sure to join us for part 2, where we'll continue to break down the most relevant updates from EULAR 2026. We will see you next time.